Good evening, everyone. Thank you so much for joining in. I am Pawan. I am Pawan from Abbott CRM Business. And basically, we are arranging this heart failure symposium series of 3 webinar. And we will have a speaker, Dr. Ramachandra sir. He is the head of cardiology department as a Sri Sri Holistic Group of Hospital, and moderator as a Dr. Rajesh sir. He is a professor and head of cardiology at Amrita Institute Medical Science, Kochi. And basically, we are arranging this 3 symposium, heart failure symposium. Today's speaker, Dr. Ramachandra, will be speaking on the hemodynamic and clinical diagnosis of different type of heart failure. So this will be the 3 series of webinar every month we are arranging. So today's topic is this, and the next topic would be etiological workflow of heart failure, and last session would be on the heart failure therapy and devices. So that is overall about it, and thank you all for joining in. Sir, over to you, sir. Yeah, I think start 7 and 7 is there. So that's it.
1 second.
Okay, sir.
What's happening, Pawan? You're muted.
Pawan, you have to enable my screen sharing. Okay. Can you see now?
Yeah, we can see us. Go to full screen.
Okay. So can you see it well now?
Very well, very well. Go ahead.
Okay. So this is basically on the hemodynamics of heart failure, because as diastolic dysfunction gets more common, it's hard to make a call on who has heart failure, or whether it's kidney failure or COPD or some abdominal problem. So with the multitude of things coming into heart failure with preserved ejection fraction, I think we need a better idea of what exactly is heart failure. So the definitions are that it's an inability of the heart to pump blood at a sufficient rate to meet the metabolic demands of the body at rest or during effort, because many patients with heart failure with preserved ejection fraction, the main symptoms are during exertion and not at rest. Or it's able to do that only if the cardiac filling pressures are abnormally high. So a very important part of the definition is the cardiac filling pressures. So the cardiac filling pressures are universally high in all types of heart failure. It is a complex clinical syndrome characterized by abnormalities in cardiac function and neurohumoral regulation also. So the neurohumoral regulation is also a very important part. Just like we have BNP as a diagnostic tool, in future we might get tests that show that we can directly measure this neurohormonal upsurge that has happened in heart failure. whether it is angiotensin or the epinephrine or norepinephrine or some other thing that we can in future measure to say that a person has heart failure. And these are accompanied by symptoms of effort intolerance, fluid retention, and reduced longevity. So that's very important. So basically, heart failure is a disease with a reduced longevity. And it's a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the blood either to fill or eject blood. So these are all the things. We need to take all of them in totality to diagnose heart failure. So the AHA 2013 definition says heart failure with, it has 4 categories: heart failure with reduced ejection fraction. This is the one in which we have all trials and all the medicines that are useful. Then we have heart failure with preserved ejection fraction, where the ejection fraction is more than 50%, but the person has symptoms and signs of heart failure. Here, the peculiar thing is no treatment seems to be very efficacious or prolonged life. Then we have heart failure with preserved ejection fraction borderline, 40 to 50% ejection fraction. And then there is a heart failure with preserved ejection fraction improved. Now, this 4th subset is not there in the ESC classification. And I think it's a very important subset in the sense that we see often people with myocarditis or hypertension who are better treated and seem to recover. But for some reason, unless we are very careful in tapering off their medicines, if we suddenly stop medicines, they seem to do worse. And there are studies that show that if this happens a couple of times, you might have lost your ability to recover their LV function with medicine. So we have to be very careful in stopping medicines or in tapering medicines in this subset. The ESC 2016 has a more pragmatic definition, like all the ESC definitions are. Heart failure with reduced ejection fraction. Signs and symptoms are a must. Then the ejection fraction by echocardiogram is less than 40%. Mid-range is 40 to 50%, just like in the American classification. And the preserved ejection fraction is the ejection fraction is more than 50%, but along with it, you need elevated levels of natriuretic peptide and at least one structural abnormality. Either it is left ventricular hypertrophy or left atrial enlargement or diastolic dysfunction. So basically, you need to tell that there is some cardiac problem there that is causing the elevated natriuretic peptides. And of course, there are symptoms and signs of heart failure. Now, this is very important because you can get symptoms and signs of heart failure and even elevated natriuretic peptides in almost any fluid overload state. So basically, if you need to point the basic disorder to the heart, you need some disease in the heart that tells you that there is that's where the increased filling pressures happen. So that's why you need these things, either left atrial enlargement, left ventricular hypertrophy, or some other evidence of diastolic dysfunction, either echocardiographic or by catheterization. Symptoms and signs of low perfusion versus congestion in heart failure, you need actually both, but some people may have predominantly one type. Low perfusion is these people have tachycardia, hypotension, cold peripheries. Some of them may have low levels of consciousness also. Many of them have metabolic acidosis. And because their oxygen extraction is more, their oxygen saturations in the venous blood are also less. So the one way to know how badly these people are faring is to get the oxygen saturation of a venous sample. And then you get a fairly good idea of how badly these people are doing. As far as the congestion, again, fatigue is a common symptom. Of course, you have raised JVP, breathlessness, hypoxemia, crepitations, pulmonary edema, and the right heart side failures of lower extremity edema and hepatic congestion and raised JVP. So if you look at these symptoms and signs, which are very, very important in the diagnosis of heart failure, because you do not diagnose heart failure unless you have these symptoms and signs. If you look at them, they have fairly good sensitivity and specificity. So the specificity is more, sensitivity is slightly less. So you need some symptoms, and then you corroborate it with some signs of diastolic dysfunction in the heart or systolic dysfunction in the heart. So you have these types of heart failure. You can have cardiac versus non-cardiac, although it might look a misnomer. This is what I was telling. Some patients with fluid overload might present with all the symptoms of heart failure, but essentially you cannot pinpoint it to the heart. You can have systolic versus diastolic, compensated versus decompensated. Really not, hardly any patients are compensated, or because they frequently decompensate. You have high versus low output. High output means the cardiac output by definition is more than 8 liters or at least 4 liters per meter square. So that is the definition. And then you, in spite of that high output, you get all these symptoms. Because we have not put slides on high output, I would just shortly go about high output heart failure. This is basically a state where the peripheral arterial system and the peripheral is dilated and the peripheral vascular resistance is low. Or there could be an AV shunt. A classical case of AV shunt could be one that you have made for dialysis, which can sometimes precipitate a high output heart failure. And a classical case of a low peripheral vascular resistance could be beriberi or thiamine deficiency. But whatever these things produce high output heart failure. A good example that is often missed is cirrhosis that produces, again, a high output heart failure in many people because of multiple AV shunts. So this is something that we need to know. A patient presents with all the symptoms and signs of heart failure, and you have to determine, many times it is possible by echocardiogram to determine that the cardiac output is high. And then you can determine the AV shunts also by various methods. Then you have forward versus backward failure, which is basically, like I said, both of them go together, but they can be predominant in some people. For example, some people can have severe cardiac cachexia with little backward failure, or some people might go into backward failure and then develop a severe cardiac cachexia because of liver involvement. Then you have dilated versus hypertrophic versus restrictive, which is an etiological way of looking at it. And then you have right-sided versus left-sided heart failure, because right-sided heart failure is a very important part of diastolic dysfunction of the left side, as well as it can be an independent situation also. One way to look at and get a good handle on the hemodynamics is through the pressure volume loop. As you can see, this is the lower part is the pressure volume loop, and this is the when the LV fills. This is the end diastolic pressure. This is the isovolumetric contraction, and this is the systolic ejection, and then comes the isovolumetric relaxation phase. So you have two very important lines in which this pressure volume loop moves. One is the end systolic pressure volume relation. Now this line denotes the contractility of the heart. So this is a much better measure of this slope is a much better measure of the contractility of the heart than the ejection fraction. The ejection fraction is quite dependent on the stroke volume. So basically the ejection fraction looks at the ratio of the stroke volume divided by the end diastolic volume. So in case this whole shift moves to the right, then actually the ejection fraction might decrease also. So the ejection fraction is not a great way of looking at the contractility of the heart, and even it can be quite deceptive in heart failures. The other loop the other curve that is important is the end diastolic pressure volume. As you can see, as the end diastolic volume increases, the pressure starts increasing very rapidly. So this is something very important. So you have basically the systolic performance, which is of the heart, which is determined by the preload, afterload, and the contractility. The contractility is by definition independent of the preload and the afterload. And then, of course, you have the diastolic function. The diastolic function of the lusitropy, which has again two phases. One is the active relaxation phase, and then there is a sort of inactive capacitance phase, so which we'll talk about later. So first we'll come to preload. One of the most important things about preload is the Frank-Starling relationship. This is because the ideal sarcomere length is around 2.2 microns. So unless that unless that length is attained, the ideal ratcheting between the actin and myosin does not happen. And that is why when the preload increases in a healthy heart, the rate of contraction, the force of contraction, everything increases. But this slope is lesser and lesser as the LV starts decompensating, in which, for example, in very severe heart failures, even a small increase in the end-diastolic volumes can precipitate severe heart failure. And this we know. It's just a couple of increases in kgs and the person goes into severe heart failure. His ejection fraction actually decreases. And then you give him some diuretics, and after a few days, you see that his ejection fraction seems better. In fact, his ECG also from a low amplitude, the amplitude increases. So there are so many things that are happening because the Frank-Starling, you are moving the patient onto the compensated form of compensated part of the Frank-Starling curve. So either way, if there is too much overlap, which means the preload is too less, or the preload is too much, the heart does not contract well. And this is the Frank-Starling curve, which is very important. So this is the preload. Actually, the preload denotes the stretch on the heart muscle, which indirectly goes on to show how much ratcheting is available between the actin and the myosin filaments, which determines the force of contraction. And in contrast to which, the afterload is the pressure against which the muscle has to contract. So this is the preload, and the afterload is the pressure against which the muscle has to contract. So the preload is dependent on end-diastolic volume. It determines the end-diastolic pressure also. Like I said, as the end-diastolic volume increases, the pressure rises very rapidly, and of course the wall stress. So as we can see, as the preload increases, many times the ejection fraction increases marginally and the cardiac output increases phenomenally. So although the ejection fraction may not increase too much, that is the reason the ejection fraction does not increase too much, although the cardiac output increases and the stroke volume increases dramatically, is because the ejection fraction is the measure of the stroke volume versus the end-diastolic volume. So as the end-diastolic volume moves to the right, the ejection fraction actually does not increase that much, although the stroke volume and the cardiac output increase. So this is the one that I was showing, the end-diastolic pressure. As the end-diastolic volume increases, as you can see, as the volume increases, it produces a disproportionate increase in the LV and diastolic pressure, so that when the curve starts moving up, this is the phase in which most of the compensated heart failures are. A slight increase in the preload might trigger a dramatic increase in the LV and diastolic pressure, precipitating pulmonary edema. So this is the reason why there is nothing like a compensated heart failure. And as you can see, even the stroke volume, sometimes when it goes on to that part of the curve, actually does not increase. And although the end diastolic pressures are increasing, the stroke volume is really not increasing, which means the person goes on to a decompensated phase or an acute heart failure situation. So this is the same curves again. Like I said, the end systolic pressure volume curve is the one that shows the contractility. And we have already discussed how the preload impinges, how it modulates the ejection fraction. So the basic, to summarize, is as the preload increases, although the ejection fraction increases marginally, the stroke volume improves rapidly. But if the end diastolic pressure volume increases too much, the end-diastolic pressure increases disproportionately, producing pulmonary edema. Now, how does decreasing preload help? There is this experimental device called Precardia, which is being tested in the US. Actually, this was started by an Indian cardiologist there. What it does is there is a SVC balloon that inflates intermittently for around 5 to 10 minutes and then deflates. Now, what this does is this decreases the preload of the heart, or the amount of the blood flowing into the right ventricle and the left ventricle also. And what it does basically is it moves these patients from a decompensated part of the Frank-Starling curve to a compensated part of the Frank-Starling curve. And what they have seen is amazing effects. The pressures, the pulmonary capillary wedge pressures fall. And very peculiarly, although you are decreasing the preload, the cardiac output is increasing. So this is an amazing thing. So what happens is, if there is too much preload, actually, like we have seen previously, the end-diastolic pressure increases, but the stroke volume is unable to increase, and actually the cardiac output might decrease. And so that when you decrease preload on these people, the cardiac output might actually improve. And not only with that, the urine output increases significantly also because of the increase in the cardiac output. A similar situation happens when you stop tricuspid regurgitation in patients with severe tricuspid regurgitation and right ventricular failure. Because the RV operates on it is very dependent on preload, and it is very afterload sensitive. Unlike the LV, this is very much forgiving as far as the ejection fraction is concerned. So even if the RV failure is there, once you stop the tricuspid regurgitation, they do well, unlike the mitral regurgitation. So we'll talk about this later, the difference between the pressure volume curves as far as the right and the left side are concerned. We come to the afterload now. The afterload is a very important thing because it is the commonest cause of heart failure, the increasing afterload. As you can see, as the afterload increases, the pressure volume loop, the total area of the loop, shows the energy that is used to pump this blood out, or the energy that the heart is using. So as you can see, this increases. So the energy increases tremendously with increasing afterload. And the person is able to maintain a reasonable cardiac output by increasing the preload also. So this is one way the afterload compensates. So the afterload is basically determined by the arterial blood pressure, the peripheral resistance, and the aortic resistance. So it is not just the arterial blood pressure. The peripheral resistance is very important, which means the resistance that the small arterioles give, the resistance that might be there at the bifurcation points from the aorta, and the resistance to the pulse wave travel itself. So all these combine to form the peripheral resistance. So the arterial pressure and the peripheral resistance are slightly different, as well as the aortic resistance. So out of these three, the most important thing is for diastolic heart failure is probably the aortic resistance. So the aorta should be a very compliant structure, but when it becomes less compliant, there is a lot of aortic resistance to the ejection, which increases the afterload. So this we'll see later. So one way the ventricle compensates to an acute increase in the afterload is called the Andrup effect. So when the afterload increases, the power of contraction also increases by increasing the calcium influx. But as we now know, anything that increases the calcium influx, although it temporarily works well, like all our inotropes, on the long run, it causes left ventricular dysfunction. On the long run, the way that the increased afterload is compensated against is by, like I said, increasing the end-diastolic volume, by increasing the size of the left ventricle, as well as by increasing the thickness. So this Laplace's law states that the tension on the wall of the myocardium is proportionate to the radius. So as the radius increases, the tension increases dramatically. For example, for the same blood pressure, say 120 systolic blood pressure, if the left ventricular volume increases by around 1/3, the tension on the wall of the muscle increases dramatically. So there is compensatory hypertrophy, and later on the compensatory hypertrophy, when it starts failing, there is systolic failure, and then towards the last part, when really the sarcomere length has increased beyond the Frank-Starling curves at all, there is a state of dilated cardiomyopathy. So you can look at this. This is somewhat like the staging of heart failure. You have a risk factor stage A, then you have hypertrophy stage B, then you have stage C, and then you have frank failure, and then refractory failure. So basically, this is a compensatory mechanism by which the stress, the left ventricular hypertrophy decreases the stress on the muscle. But what it does is it increases the oxygen consumption, and like we know, anything that increases the oxygen consumption of the heart will ultimately lead to heart failure. So these are the afterload the measures of afterload include wall stress, which I just talked about now, which depends on the size of the ventricle. For example, a heart size that is bigger is always subject to more wall stress, which is the reason why almost all heart failures have a downward course, because the increased wall stress means that the ejection fraction as well as the myocardial oxygen consumption increases. Then the arterial pressure and the vascular resistance. So anything like which decreases this vascular resistance will increase the cardiac output. And this is one where the drugs work. Also, anything that can actually pump out blood from the ventricle acts much better than any other systemic circulatory aid. For example, this is like an impeller device, which has approval for heart failure with acute decompensation with cardiorenal syndrome. If you use this, what it does is it decreases the afterload and the preload on the heart, and puts them into a compensated phase. So like I said, the most important cause for heart failure is the arterial pressure, arterial resistance, and the aortic resistance. So there's something called the central aortic BP, which we are all aware of, and which is different than the peripheral blood pressure that we measure. The problem is, as the aorta becomes stiffer, for it to accommodate the systolic, sudden systolic increase in the volume when the heart pumps blood into the aorta, as the compliance decreases, the blood pressure suddenly goes up. So that the central aortic blood pressure, actually, which should be much lower than the peripheral blood pressure, actually goes down. And this we can measure now by different types of blood pressure devices that use some sort of applantation tonometry to look at the pulse wave also. So they look at the blood pressure and they look at the pulse wave and indirectly tell us what is the central aortic blood pressure. So like I said, the vascular resistance is very important. Normally when the heart pumps, the aorta should and what it does is it somehow dampens the sudden increase in blood pressure by increasing the volume, and later after the dicrotic notch, it actually contracts, somewhat behaving like an IABP or whatever, to increase the blood pressure. So this is the way the aorta sort of cushions the pulsatile thrust of the heart into the aorta. But once the aorta is stiffened, this property is lost. And not only that, the aorta itself, but depending on the bifurcation points and other things, there is a reflected wave that actually summates onto the original wave also. So as we know, as we go peripherally, the pressure increases. And this is because of the pulse wave velocity that is conducted through the vasculature. Many people confuse the pulse wave with the actual blood. So actually the blood is not flowing at a number of meters per second. So the pulse wave velocity is calculated by seeing how the pulse wave travels. So the pulse wave is not the actual blood that is traveling, but actually a wave of pressure that is transmitted through the walls of the vasculature. If you look at the actual travel of the flow of the blood, you can see it is much less. You can see here, it is not even a meter per second. So it is not the actual blood that is producing the pulse, but it is the pulse wave. So when the pulse wave flows to the periphery, there is a reflected wave. And as the arteries become stiffened, this reflected wave, which should normally, like here, this is the reflected wave, the blue curve, which should normally fall almost after the dicrotic notch, gradually moves up, and it starts falling before the dicrotic notch and sorts of augments the systolic blood pressure. So you can see here, if this is the actual pulse pressure being generated, the reflected wave adds to it, and this is called the augmented part of the pressure. Now this is very important. This is called the augmentation index, or the actual augmented part of the blood pressure, which can be measured in millimeters. And this is probably one of the most important causes of heart failure. So what this does is it increases the central blood pressure, it increases the systolic blood pressure, it increases the LV afterload. But because this wave has moved from here to here, it decreases diastolic blood pressure and decreases coronary perfusion. So you can see how a shift in the temporal profile of the reflected wave has such bad effects on both the perfusion as well as the afterload of the heart. Now, for the same blood pressure, people can have different augmentation indices. For example, you can see here, this is a low augmentation index, this is a high augmentation index, the same blood pressure. So we don't need to use only the absolute measures of the peripheral blood pressure that we measure. We can use the central aortic blood pressure, and we should also use the augmentation index, because there's good evidence that people with high augmentation index, if you lower their blood pressures more, then their heart failure decreases and their BNP levels also decrease. The other thing is the heart rate reducing drugs like the beta blockers. Beta blockers have been shown to increase the augmentation index. This is probably one reason why they do not decrease mortality and why they are inferior to drugs that decrease the augmentation index, which are peripheral vasodilators like the ACE inhibitors or the calcium channel blockers. So does this apply to ivabradine also? There have been studies with ivabradine, and very peculiarly, ivabradine has been shown to very marginally or not increase the augmentation index. So whether it is a function of bradycardia or whether it's a function of the drug's inability to decrease peripheral vascular resistance, the beta blocker drug's inability to decrease peripheral vascular resistance is something we need to see later. So these things give rise to something called the ventricular aortic coupling. So this, like we said, is the end systolic pressure volume relation. And then there is, this gives you the what is called the elastance at the end systole. So this is a measure of the cardiac contractility. And then there is something called the elastance of the aorta. This is the LV end systolic pressure divided by the pulse pressure. So both of them, this, if you divide that by this, it should be 1. And if it falls below 1, you know that the heart is failing, or at least it's going to fail. So this is a very important measure hemodynamically that tells us that a person is very prone to heart failure, even though his ejection fraction might look normal and his blood pressures might look normal. A good example of increased afterload producing diastolic as well as systolic dysfunction is the low gradient aortic stenosis. Now, as you know, low gradient aortic stenosis are divided into 3 subsets. One is a ejection fraction low. The other one is ejection fraction which is not low because of the hypertrophy of the heart. Now, this is a big fallacy with the ejection fraction. Now, like I said, the ejection fraction seems falsely high if the end diastolic volume is less. So if there is hypertrophy, the end diastolic volume is less, so the ejection fraction looks good. but actually the cardiac output is less. So this is called the paradoxically low flow gradient. And then there is another very peculiar variant of normal flow low gradient. So we have methods to assess this. We can do a dovetamin stress, or if there is a confusion, we can do a CT or look at the valve opening by esophageal echo, or by CT. If there is a huge amount of calcium, then we know that there is a severe aortic stenosis, so we need to replace it. So this is a workflow of that type of situation where the increased afterload has produced either a decreased ejection fraction, or it has caused a left ventricular hypertrophy where the ejection fraction falsely looks normal, but the cardiac output is less. So in this case, you can do a dovetamin echo, and if the gradients are increasing, then you know that it is truly severe. If the gradient is not increasing, but the aortic valve area is less, it might mean that the heart does not have any flow reserve, which means even your dovetamin is not able to increase the contractility of the heart. So in which case you have to depend on the other two modalities, which is TE or multi-slice CT. And of course, the other variant is the paradoxical one, where because of the decreased end diastolic volume, the ejection fraction is normal. Here also, because the cardiac output cannot be increased significantly with the dovetamin, you have to depend on your other modalities. So this is a case where it nicely tells you of the fallacy of ejection fraction. Now we come to a situation where there is both increased preload and afterload. This is aortic regurgitation. Here you can see in the pressure volume loop, there is hardly any isovolumetric contraction or isovolumetric relaxation. The cardiac output has increased hugely, although the ejection fraction has not increased that much. So here again, like we said previously, rather than depending on the LV ejection fraction, what we have to look at is at the contractility of the heart, which means we look at the end systolic dimensions of the heart, or the end systolic pressure volume loop. So if you're not able to get the end systolic pressure, at least we can develop the end systolic volume, and this is what we do in determining who needs surgery. As you can see, any symptomatic patient with the end systolic diameter of more than 50 or more than 55, his ejection fraction is normal. So despite ejection fraction being normal, if the end systolic diameter increases, it means that the person needs surgery. The other thing to know is if the blood pressure is reduced, the aortic regurgitation fraction decreases. But many people do not realize that if you decrease the heart rate, the regurgitation fraction will increase. So one thing to do in aortic regurgitation is not to decrease the heart rate, which is quite the opposite of mitral regurgitation. In mitral regurgitation, if you decrease the heart rate, the regurgitation fraction will decrease. In aortic regurgitation, because it is mainly in diastole, the regurgitation is happening in diastole, you should not decrease the heart rate. Now we come to a situation where the afterload is decreased rather than increased, and this is mitral regurgitation. Here again, you can see because of the decrease in afterload, there is an increase in the stroke volume, and here actually there's an increase in the ejection fraction also. So because of the falsely increased ejection fraction here, although the contractility might decrease, you can see here this slope, actually the contractility is decreased, which means the end diastolic pressure, the end systolic pressure that is being generated is actually less, which means the contractility is decreasing, but the ejection fraction looks good. So this is another place where your ejection fraction misleads you. So here again, you depend on the end systolic volume, like the end systolic diameter is more than 40 or 45, despite a normal ejection fraction. That is the time you need to do something about the mitral regurgitation if the person has the symptoms. If the person has pulmonary hypertension or left atrial enlargement also, of course, we need to do it. with the advent of mitra clip, we used to think that the RV is very compensates well, but the LV does not compensate well if you stop the mitral regurgitation, because you are stopping the ejection into a low pressure circuit. But if probably if you keep the mitral valve apparatus intact, even if the LV ejection fraction is reduced, what the mitra clip studies have shown is that they do fairly well. So probably it's the technique of the mitral valve repairs or the replacement that is preventing these improvements in ejection fraction in people with low ejection fractions with mitral regurgitation. The third thing is contractility. Like I said initially, contractility is independent of the preload or afterload. So you have to keep the preload and afterload same. So this can basically happen only in experimental models. And the contractility is determined by the end systolic elastance. And this is determined by the end systolic pressure by volume curve. So as you can see, as the contractility increases, this thing moves to the left, and as the contractility decreases, this slope starts decreasing. The aortic elastance is just the opposite. The aortic elastance is the end systolic pressure divided by the pulse pressure. So as the aortic elastance increases, the elastance of the end systolic elastance of the ventricle decreases. So we have already talked about the fallacies of ejection fraction as a marker of contractility. So it is not an independent marker of contractility. The most closest independent marker of contractility is the end systolic volume. And if you can get end systolic pressure also, that will tell you even more about the contractility of the ventricle. Now we are all bent on increasing the contractility of the heart. But we have three ways to do it. We have these calcitropes, which are all the inotropes that we know that they increase the calcium inside the contraction apparatus. And then there are the myotropes, which are drugs that increase the ratcheting of the actin-myosin. And then the mitotropes, which actually increase the energy production and the better energy utilization at the mitochondrial level. So omecamtiv mecarbil is one such drug that actually increases the duration of systole by increasing the overall active cross bridges. So thereby it increases the stroke volume, and very peculiarly it does not increase the oxygen demand of the heart. So this is where the newer drugs are coming, unlike the all the previous drugs that we have, which are calcitropes, which actually increase the calcium there. All these drugs that we have, which we know increase the long-term mortality, these drugs do not increase the oxygen consumption of the heart muscle, but they increase the cardiac output. And this is one way probably they can improve the lifespan of these patients. As you can see, trimetazidine also has this mitochondrial action, whereby it decreases fatty oxide, increases the fatty acid oxidation. So we have trials on this. I think most cardiologists will be aware of these trials. And then there is a drug that increases the soluble GMP levels also, the soluble guanyl cyclase levels, which increases the cyclic GMP at the cellular level. And this also very peculiarly increases the cardiac output without increasing the oxygen consumption of the heart. So this is very key guat. This also does the same thing like the previous drug, that it increases the contractility without increasing the oxygen consumption of the heart. The third mechanism that does this is a pacemaker that actually gives out a pacing spike in the absolute refractory period of the heart. And this also has the European approval to be used in patients with heart failure, which we'll discuss when we are talking about devices for heart failure. So this also improves the contractility of the heart without increasing the oxygen consumption of the heart muscle. So when we are talking about the oxygen consumption, like I said, the total area under the pressure volume loop denotes the oxygen consumption, as well as the curve, between the curve denotes the latent oxygen consumption also. So the whole thing, if you look at it, the pressure volume loop, this is what determines the oxygen consumption. So that if this curve moves this way, which means the preload increases and it moves this way, although the cardiac output increases marginally, the oxygen consumption increases disproportionately because this latent energy is also needed. So this is the energy that is not actually used in pumping, but it has to be provided to the heart muscle, which means that more these things move towards the right, whether it's because of increased afterload or preload, the heart has a tendency to consume more oxygen and start failing. So the three major components of oxygen consumption are the basal metabolism, calcium cycling, and the actin-myosin coupling, which is the active part of the pressure volume loop. So actually this calcium cycling is also something that keeps happening even in the rested heart if it has to stay alive, which means even if you have a device that is helping the heart to pump and really the heart is not pumping, even then it needs quite a bit of consumption. It consumes quite a bit of oxygen just to stay alive because the calcium has to be cycled. So this is what I was telling, whether the afterload is increased or the preload is increased, the oxygen consumption is increased. If you increase the contractility, the oxygen consumption is increased, but not by these other mechanisms. Like I said, only if you are using the calcitropes, then only the increased calcium cycling, which is a major component of the MVO2, is expended. Otherwise, if you use some other mechanism to increase the inotropy or the contractility, this part is not used. And that is where the future of the drugs or devices for heart failure will be. The heart rate is also a very important marker of the MVO2. As you can see, each beat takes the same, consumes the same thing, so that if you decrease the rate, the MVO2 decreases dramatically. And this is one way that decreasing heart rate, whether it's by beta blockers or ivabradine, might be helping patients with heart failure. So we'll come to the diastolic part of the heart. The diastolic part has compliance and capacitance. So it basically has a rate of relaxation and the extent of relaxation. So you can look at it this way: the rate of relaxation and the extent of relaxation. And the extent of relaxation depends on the compliance and the capacitance. Now, what is the compliance? See, as the pressure, as the volume increases, the pressure increases. So this ratio is called the compliance. So the stiffness is just the other part of the ratio. So if you get the end diastolic pressure volume slope, if you divide it by 1, if you inverse it, 1 by that volume, 1 by stiffness will give the compliance. So basically it is the same thing. As the stiffness increases, the compliance decreases. The capacitance is slightly different. The capacitance is dependent on the size of the ventricle, so that if the size decreases, the capacitance decreases, which means the total amount of the blood it can hold at a particular pressure decreases. As the size increases, like in remodeling, say after a myocardial infarction, the LV size becomes bigger. What happens is the capacitance is increased so that even with a lesser ejection fraction, it can produce the same stroke volume and maintain the same cardiac output. So as you can see, the capacitance decreases. The word capacity itself makes it easier for us to remember. The capacitance decreases when the LV size decreases. So this is different from compliance. Compliance means it is a measure of the way the heart relaxes. whereas capacitance is a measure of the heart size. So lucitropy, if you look at it, like you have this, it is measured by tau, which depends on the active ATP dependent uncoupling, and it increases with ischemia and decreases with heart rate and beta agonists. So we all know that beta agonists also increases the lucitropy, so that in decompensated heart failure, they might actually increase, work against diastolic dysfunction also. So this is the measure that is usually used to tell us the active relaxation. It's called the TAU or tau. And how it is determined, it can be determined even by echocardiography also. So we have these ways of producing mechanisms by which the hemodynamic mechanisms by which LV diastolic dysfunction is produced. One is the compliance is reduced, which means the tau is increased, which means it does not relax well or it relaxes very slowly. The other one is that the capacitance is decreased, which means it initially seems to hold well, but then either there is a restrictive cardiomyopathy or hypertrophy or pericardial constraint, and then suddenly the capacitance, its LV is not able to hold that much volume. Or the whole volume curve has shifted to the right, producing increased LV and diastolic pressure, which is typically happens in heart failure when the preload is increased as a compensatory mechanism to keep the cardiac output despite a decreased ejection fraction. So these are the ways in which diastolic dysfunction happens, and as you can see, almost every patient with systolic dysfunction will have some amount of diastolic dysfunction, and 50% have measurably significant amounts of diastolic dysfunction. So all systolic dysfunctions have some amount of diastolic dysfunction because the curve has moved to the right with increased LV and diastolic pressures. We come to the hemodynamics of heart failure with preserved ejection fraction. Now, this is a very difficult disease. It is basically the heart plus the metabolic syndrome plus the kidneys and the lungs. So you have LV diastolic dysfunction. Some patients have systolic dysfunction, which is of a very mild nature. Most patients have pulmonary hypertension, or at least they develop pulmonary hypertension when they exercise. Because of pulmonary hypertension, there is some amount of RV dysfunction, which is disproportionate to the symptoms. And the LA enlargement is also there, which is a very common marker and which many echocardiographers use. If the left atrium is enlarged, it is a surrogate marker to say that the person has LV diastolic dysfunction. And then, of course, there's vascular stiffening, like I was talking about the aorta. There is the microvascular dysfunction, which is a very important component of the diastolic dysfunction, which is probably a result of the increased pressure across the myocardium, but it goes in a vicious cycle, which means the decreased blood flow actually increases stiffness. Peripheral vascular disease is there, as well as peripheral oxygen extraction, and general oxygen extraction is also a problem. And then there is chronotropic incompetence, which is a very important part of HFpEF. Because of chronotropic incompetence, these people have disproportionate symptoms when they exercise. Now, these are the ways in which most cardiologists or non-cardiologists will also diagnose LV diastolic dysfunction, left atrial enlargement, left ventricular hypertrophy, elevated RV systolic pressures, RV enlargement, and minor LV dilatation. So these are the things we look for when you get a patient with symptoms of heart failure, but his echocardiogram almost looks normal. So you basically look at any hypertrophy, you look at any atrial enlargement, you look at any pulmonary hypertension, especially if you can make them exercise and look for pulmonary hypertension. That will tell you whether the exercise is producing the diastolic dysfunction. So you have this clinical history and physical examination. Sometimes if the person has obesity or atrial fibrillation, especially atrial fibrillation, is almost a marker for diastolic dysfunction. So in these situations, should be very careful that the person to suspect diastolic dysfunction. Then in the echocardiogram, of course, a very important and easy method is the E by E prime ratio. The E is the inflow velocity, the E flow is the Doppler velocity of the mitral valve pulling down, and the systolic pressure and the left atrial enlargement. So these are very easy ways. And now, of course, the global longitudinal strain, which most machines automatically complete and give us. So echocardiogram is the sheet anchor of diagnosis of heart failure, which was not the case when we did not know these measures previously. We used to depend only on ejection fraction, and that was where we used to have the problem. And then, of course, the other big change is the natriuretic peptides, the NT-proBNP, which we are looking at. But then you have to know that if the LV wall is thickened and the cavity is small, you may not get high BNPs, and also in obesity, you may not get high BNP. So these are the two areas where you will not depend totally on a BNP. And then, of course, exercise testing, like I said, is a very important part of it. If you exercise and you can see that the pulmonary wedge pressure or the end diastolic pressure is going up, or the pulmonary artery pressure is going up, then you know that the person has HFpEF. So there are different tables that tell us about HFpEF. This is a simple algorithm. If the person is heavy, hypertensive, atrial fibrillation, pulmonary hypertension, elderly, increased E by E prime ratios, then you can easily diagnose heart failure. The European Society also has a similar acronym, which we can look up, HFpEF, and it actually tells you the steps in which you can diagnose heart failure also by simply remembering this acronym. The echo is very important. Like I said, if you don't get these findings on a normal echo, you can stress the person by whatever way and see that the E prime ratio, E by E prime increases, as well as there is pulmonary hypertension. So if you make the person exercise and the E by E prime ratio increases, as well as this pulmonary hypertension, you know that the person has HFpEF. And you can use similarly invasive monitoring also and make the person exercise. If you don't want to make the person exercise, sometimes you can infuse around 500 ml of normal saline over half an hour and get similar findings where the LV and diastolic pressure increases, or the pulmonary capillary wedge pressure increases, and there is pulmonary hypertension. So basically, when you exercise or when you give a volume overload, if the pulmonary capillary wedge pressure increases or there is pulmonary hypertension, it's an indirect evidence of heart failure with preserved ejection fraction. Then we come to the situations where the relaxation or the capacitance of the ventricle is suddenly decreased. This is the typical case in constrictive pericarditis, where you get this square root sign where it rapidly fills, and then the full capacitance of the heart is reached, and then there's a plateau. So this is the square root sign that is present in constrictive pericarditis, and also happens in some cases of restrictive cardiomyopathy. So basically, you have the same hemodynamics translating into the jugular venous pressure. In constrictive pericarditis, you have sharp X and Y descents, whereas in tamponade, you have only the X descent, because most of the cardiac filling happens when the AV rings go down, and not during diastole, but actually in the systolic phase of the LV contraction. So in case you get ephesoconstrictive pericarditis also, you might look at the JVP to help you if there's an element of cardiac tamponade. So this same hemodynamics translate into the JVP to help you make the diagnosis. You can look at the Kussmaul also. Normally the JVP should fall, but it increases because of the decrease in the capacitance of the ventricles. And not only is the capacitance decreased, but because of the interventricular septum might bulge to the left, you might get some of the symptoms of cardiac tamponade, like even pulsus paradoxus in these patients. Previously, constrictive pericarditis was a very difficult diagnosis to make. Many people needed cardiac catheterization, especially if you wanted to differentiate from restrictive cardiomyopathy. What they were looking was increased filling pressures, which were there in restriction, but not in constriction, because in constriction, both the right and left ventricles are constricted. So you cannot get a grossly increased filling pressures, but that happens in restrictive, as well as the square root sign and the other hemodynamics like the systolic pressure were looked at. But now with the tissue E by E Doppler velocities, it becomes very easy. You can see these are the sensitivity and specificity of the echo findings, the ventricular septal shift, the change in mitral E velocity. And like I said, in constrictive pericarditis, because the LV is actually contracting and relaxing well, the E prime ratio, E prime is good, which means it is not decreased, whereas the E prime is very much reduced in restrictive cardiomyopathy. So this is a very easy way to tell you that if there is a basic myocardial problem, or basically there is a constrictive problem, it becomes very easy, as well as the median bilateral E prime, because we know the lateral part is restricted in constriction, but not the medial part of the E prime, which means that the tricuspid, you can, or the mitral, you can measure the lateral part as well as the septal part of the E by E prime. And the hepatic vein diastolic reversal, which happens in expiration. Also, if you look at all these things, you can easily diagnose constrictive pericarditis quite easily, especially if you also look at visualization by CT or MRI to look at the pericardial thickness. So once you know that the pericardium is thickened and you know that the heart is relaxing well, then you have the diagnosis of constrictive pericarditis. So these are the same things. Basically, the mitral annulus velocity, you can see, is actually pretty good. Actually, it's increased also, whereas in restrictive, it's grossly decreased. So this is the very important thing to tell you between restriction and constriction. You can also look at the way sometimes, as you know, COPD also will give some signs of constriction, but here the diastolic flow reversal is not there in expiration, but in inspiration. And we have explained that you can look up later the hemodynamics of why it does it. But here again, if you look at the velocities, the input velocities also, it actually increases during inspiration, whereas in constrictive pericarditis, it decreases during inspiration, if you look at the mitral and tricuspid velocities. So patients with symptoms and signs, so you look at how the diastolic function is. If the mitral E velocities are decreased and there is disproportionate bilateral and atrial enlargement, it becomes restrictive. If the mitral E velocity, E prime velocities are increased and there is increased respiratory flow variation along with the septal bounds, then of course constrictive physiology. So very easy nowadays to make this differentiation without catheterization. The last thing we are going to talk about is RV failure, because we have already talked about forward versus backward failure. The only thing we have talked mainly about LV failure, but RV failure is a very important component because some amount of RV failure happens in most patients with HFpEF. Now, why this happens is normally the RV is a very compliant and a large structure. Actually, if you look at it, the RV volumes are more than the LV volumes. And it stretches significantly for any increase in the afterload. So these are the pressure loops. So normally, as you can see, this is the pressure volume loop. And with chronic pulmonary hypertension, it somehow maintains it increases its contractility and maintains the stroke volume. But if there is an acute increase in the afterload, the stroke volume falls and the person can actually go into shock. So the RV output is very sensitive to both preload and afterload. As we know, if the preload decreases, the person might, cardiac output might drop because the RV is a very thin structure. It's dependent on the preload. And similarly, because of it being a thin structure, and normally the inertia of the blood flow itself maintains flow through the RV into the pulmonary arteries. As you know, many of the congenital cardiac surgeries that exclude the RV depend on this flow of the blood, the flow velocities that propel the blood from the vena cava into the pulmonary artery, even with the exclusion of the RV. So once there is increased afterload, the RV starts failing very dramatically. And this is what happens in pulmonary embolism. Unlike the left ventricle, where the thickness of the left ventricle prevents the LV from failing due to acute increases in peripheral vascular resistance or in the blood pressure. So this does not happen in left ventricle, but this happens very commonly in the right ventricle, that if there is an acute increase in the pulmonary pressures, the right ventricle will fail, like in pulmonary embolism or even in an acute exacerbation of COPD. So this is the same thing that shows that as the right atrial pressure goes up, after one stage, the cardiac output decreases dramatically on the right side. The other thing is that for many years, people used to feel that the RV dilatation is not a significant contributor to LV dysfunction in patients who have RV dilatation. Now they know that this produces significant effects when the shape of the left ventricle is changed. Not only that, the shape of the right ventricle also, when it changes, it dramatically impacts its pumping capacity. As you all know, one way we look at RV function is the TAPC, or the way the tricuspid valve is pulled down. The main ejection fraction of the right ventricle happens by a longitudinal shortening. And when the RV dilates and its shape changes, the TAPC also decreases markedly. So these are the ways you look at the RV function. As you know, you look at the tricuspid regurgitation velocities, you look at the TAPC, you look at the actually the change in the, you can measure the change in the volumes. You can look at the tricuspid annular velocities, longitudinal strain, which is now available in most machines. And if you want some other visualization like MRI or even a CT or a radio nuclear ventriculogram, you can get proper estimates of the RV ejection fraction and size. So in case of RV dysfunction, we have a lot of literature on RV dysfunction and how to manage. The key takeaway points of RV dysfunction is you have to look at cardiac output and you have to look at the central venous pressure. Now, there was a phase when people started saying that central venous pressure measurement is not important, which means that in a person with, say, an acute heart failure due to a right ventricular myocardial infarction, you can maintain very high CVPs or don't need to measure CVPs, give as much volume as you want. But now they know that if the CVP increases significantly, the RV might stretch and there might be a prolonged effect of this RV dilatation or some amount of irreversible effect also. So you need to measure the cardiac output, and a good measure of the cardiac output is the pulse pressure in the acute phase and the oxygen extraction by the venous oxygen concentration, and on a long-term phase means you have the urine output. So basically the diuresis and other treatments depend on the urine output and the CVP. So you need to look at these two things to know how much volume to infuse in these people. Thank you.
That is superb, Ramachandra. You went on to elaborately talk about different hemodynamics of heart failure, starting from definitions of heart failure. Then you talked about how ejection fraction is a poor marker of contractility. And you explain different disease conditions like paradoxical low flow, low gradient AS, how ejection fraction may not be a good indicator of the uh, cardiac output and all, etc. Then you also discuss about different the ventricular atrial coupling and other the associations in heart failure. And then you describe different disease conditions like aortic regurgitation, mitral regurgitation, and then you explained about RV and how important it is to measure RV function and diastolic dysfunction. Any other questions we can take it? Any questions on the chat box?
Sir, no question from chat box, but we can always ask for the participant if they have any questions. Dr. Ramachandra will address the same. So please share whatever your question or the. Okay.
So I think next month, I think the same date we'll discuss about the etiological diagnosis of heart failure, which is a very important thing. Because once we have taken an angiogram and once there is an echo, that is where we stop, most of us. And we don't know, we just declare them as dilated cardiomyopathies or restrictive cardiomyopathies. And we are not really looking whether they are having a reversible myocarditis, whether they have sarcoidosis, whether they have infiltrative disorder. So basically, we need to know how to work up these patients with heart failure and how to see if they have any reversible causes of heart failure. So that's a very important thing, because it is not just ischemia most of us just do an angiogram and an echo and then we are done with it. We label them as idiopathic dilated cardiomyopathies. So I think the etiological workup of heart failure is very important, and we'll discuss that.
There's a question in the chat box. How do you measure the right ventricular ejection fraction? This is from Sunil Kumar.
Yeah, so basically the ejection fraction of the right ventricle can be measured, but the ejection fraction of the right ventricle is even less important, definitely much less important than the ejection fraction of the left ventricle. So the right ventricle ejection fraction is less important. What is more important is the cardiac output. So the cardiac output can be measured on echocardiogram by the simple ways, just like you measure the on the echocardiogram, you look at the velocity time integral at the aortic valve and the radius of the aorta or the LVOT. So by the same mechanisms, you can measure the right ventricular output. If you want to look at the right ventricular function, then of course the TAPSE is the method that all of us use. But you can also measure the ejection fraction by different algorithms that the newer machines have. Newer machines means almost all the new machines are having this. When you push the right ventricle, they use a modified Simpson's method, which is not like a bullet, but like the shape of the RV. So as you can see here, they can determine the total ejection fraction of the RV by an echocardiogram, and also you can determine the RV longitudinal strain also, just like you do the longitudinal systolic strain for the left ventricle. So it's not that difficult nowadays to measure these functions. Only problem is that we don't do it all the time. So basically, to summarize, we can actually measure the ejection fraction. We can measure the cardiac output, which is more important. We can measure the systolic contractility by TAPSE or by the longitudinal strain. And we can definitely look at the pressures. For example, the IVC contractility, if it does not collapse, we know that the pressure there is 12 to 15 millimeters or more. So like that, you can measure all the components of the right ventricular function.
One accurate way of actually measuring RV ejection fraction is by CMR. The CMR is so good in actually tracing out the endocardial borders so well Similarly, you can get a very accurate assessment of RVEF by CMR.
Correct. Not only that, you actually get a very good etiological diagnosis also, whether it is ARVD or whether, the shape of the tricuspid annulus, what has happened and why there is tricuspid regurgitation, because most of these people have tricuspid regurgitation compounding the problem. So you get a very good etiological diagnosis. And like we said last time, CMR is one thing that all cardiologists should learn. Just like we know echocardiogram, I think this is the future echocardiogram.
Right. Any other questions the audience wants to ask? They can either type in the chat box or unmute themselves and ask directly.
So I think we can end it now, Pawan, because they don't seem to have any questions. And
yes, sir.
And Pawan also.
Yeah, yes, sir.
This opportunity, and Dr. Rajesh for having moderated, taken time off to have moderated, and the audience that has taken time off on Sunday to participate in this. And thank you all of you.
Thank you. Thank
And
you.
Dr. Nikhila also.
Thank you so much, sir.
Hosting
Yeah.
this call.
Thank you.
Okay. Thank you so much, sir, for giving us opportunity of this learning and sharing your feedback, sir, and our opinion on the heart failure, sir. Thank you so much, sir, for sparing your time, sir. And also thank you to Dr. Rajesh, sir, also for sparing his time, sir. Yeah. Thank you so much, sir. Bye, sir. Good evening, sir.